Welcome, everyone. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist with the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, feel free to use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and the guest speaker will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask a doctor. So next, I would like to introduce you all to Dr. Duncan Moore. Dr. Moore is a second-year rheumatology fellow at Mass General Hospital. His clinical and research interests include rheumatoid arthritis, Lyme arthritis, scleroderma, and musculoskeletal ultrasound. He joins us today to give a talk on rheumatoid arthritis, but before we get started, Dr. Marcy Bolster, would you like to introduce yourself?
Yes. Hello, everyone. I'm Marcy Bolster, and I'm a rheumatologist at Massachusetts General Hospital. I am the program director for the Rheumatology Fellowship Training Program, and therefore I work very closely with Dr. Moore, and he is truly exceptional, and I'm excited for him to be able to talk to you today about rheumatoid arthritis. It's a condition that we commonly see, and I think he will present information to answer many questions. If there are questions that come up, I will be able to see the questions towards the end of the session. We'll have the questions submitted towards the end of the session, and I'll be able to pose those to Dr. Moore. Thanks for joining us.
Thank you. So now we'll hand it over to Dr. Moore.
All right. Thank you, Amy. Thank you, Dr. Bolster. Let me just share my screen. Here we are. Okay, excellent. So again, I'm Duncan Moore. I'm a second-year rheumatology fellow here at MGH, and today we'll be talking about rheumatoid arthritis, the most common type of autoimmune arthritis. And so to get things started, I have no relevant disclosures to make. And okay, let's start with a case to sort of frame our talk today. And this case is a 35-year-old woman, previously healthy. And she goes to a primary care doctor because she's been having several months of progressive stiffness, swelling, pain, warmth, and tenderness in her joints. They're the small joints of her hands, as well as her wrists. She's been experiencing fatigue over these last few months as well. And she notes that the symptoms, they improve partially with ibuprofen. They'll get better for a few hours before they reemerge. This has been a persistent situation for a few months now. And so on exam, she has tenderness and warmth and swelling at her knuckles and her wrists. So her primary care doc gets some labs, the rheumatoid factor, also known as RF, and the CCP antibody, and those are both positive. So at this point, the primary care doc refers this woman to a rheumatologist. Okay, so this talks about rheumatoid arthritis. Well, what is rheumatoid arthritis? First and foremost, it's an autoimmune disease. And so that means a disease in which the body's immune system, which is, of course, normally fighting invaders and pathogens, viruses, fungus, bacteria, and importantly, not recognizing the rest of the body as foreign, starts to recognize part of the body as foreign and attacking it as if it is an invader. In rheumatoid arthritis, this autoimmune disease, this attack is manifest primarily in the joints of the arms and legs primarily. And of course, the manifestation of the attack, the autoimmune cell attack, is inflammation. And inflammation, creates warmth and swelling and these kinds of features I described. This disease, if it's, it is chronic, and so it progresses. And if it's left unchecked, it can be destructive and deforming of the joints. However, this inflammation, this damage The inflammation can be treated with anti-inflammatory drugs as sort of a temporizing measure, but fundamentally with immunosuppressive medication, this process can be arrested. And again, as we mentioned in the title, this is the most common type of autoimmune arthritis. It's actually quite prevalent. In the United States, it's estimated that about 0.5% to 0.75% of all people, all comers, all ages, have this disease. Similar rates in Northern European populations. And so you take 100,000 people in the US, every year, 40 of them are going to newly develop rheumatoid arthritis. And so what does a classic case of rheumatoid arthritis look like? So those symptoms I mentioned in our case, they're usually gradual in onset, they're progressive. The kind of chief earliest symptom often is the stiffness in the hands or the affected joints. There'll be swelling and warmth of the joints that are affected. Rheumatoid arthritis, one hint to that it is rheumatoid arthritis is the sort of characteristic distribution of the involved joints. And so you can see these little circles highlighted here in the hands. You know, the joints that are involved are generally symmetric on both sides. And early on in the disease, it typically involves small joints in the hand called, the fingers rather, called the MCPs, the metacarpal phalangeal joints. You can see me circling them here with my pointer. They're also the ones that are in these dots, these circles rather, here. So those are sort of the big knuckles, so to speak. And then there's the intermediate, the kind of middle knuckles. You can see them kind of swollen and prominent in this diagram here. That is these circle joints here. So those are the MCPs and the PIPs. Those are sort of the chief characteristic joints. But of course, the wrists can be involved. So that's this part down here. The bones within the hand can be involved. You can see these areas of red. Those are areas where the inflammation is occurring. But of course, it can affect medium and large joints as well. It can affect elbows, shoulders, knees. It also commonly affects the toes. So the sort of big knuckle joint at the bottom of the toe called the MTP, the metatarsal phalangeal, is often involved. And so one thing that's a feature of arthritis that's mediated by inflammation, by those cells infiltrating into the tissue and causing that inflammation locally, is that stiffness tends to actually get better with use. And so often people will note that their symptoms are more prominent in the morning, and they improve actually with use, going about their day over a few hours. So RA is a systemic disease. It affects the whole body. And although the joints are sort of the chief manifestation, the inflammation sort of is a system-wide feature. And that sort of generalized inflammation can cause other effects such as anemia, weight loss. And with this disease comes a lot of fatigue, sort of a generalized fatigue sensation. Depression can be a prominent feature. And then, of course, besides the attack on the joints and the joint capsules, which is called the synovium, it can affect other tissues, what we call extra-articular tissue damage rather. And so you can get nodules underneath the skin, classically on the kind of outer part of the elbow here. You can get inflammation in the lungs, and so you can see this CT scan. So this is a slice kind of through the middle of your chest. You can see these areas in the back of the lungs that are fibrotic and sort of reorganized. And this is not normal lung that exchanges air normally. And so there can also be inflammation besides the lungs, besides the joints. There can be inflammation surrounding the heart and lungs. It's called pleurisy or pericarditis. There can be damage to the outer parts of the eye, scleritis, episcleritis. There can be autoimmune infiltration into blood vessels, which is called vasculitis. So it unfortunately is a systemic disease that can have lots of effects beyond the joints. Very important to think about as we watch our patients and treat them long term. These are things we're looking out for. So what causes rheumatoid arthritis? Well, the short answer is we don't know, but there are some hints to what may cause it. And that can sort of be brought out from the factors, the risk factors that are associated with developing the disease. These risk factors don't prove causality, but they sometimes, in some cases, might suggest it. So I'll start off by kind of the last 2 points. Chronic inflammation of the mucosa, the tissues of the lungs, the airways, the tiniest little air sacs in your lungs called alveoli. Chronic inflammation of those from cigarette smoking chiefly, but also chronic inflammation of the gums, periodontitis. Chronic inflammation in our mucosal tissues is thought to be part of the process of how RA develops. There's a lot of research that's been going on for a long time looking into this, and I think in the coming years we will have a better understanding of what truly the chain of events that causes your body to lose what we call self-tolerance, basically tolerating itself while destroying invaders. The process for that may involve, it certainly involves environmental stimuli, but there's also more sort of inborn components, you could say. For example, you can see there's a family predisposition to rheumatoid arthritis. If a first-degree relative, such as a parent, has rheumatoid arthritis, your risk is 3 times higher that you will go on to develop it. Second-degree relative, so 2 steps away, grandparent, for example, it's a 2-fold higher risk in you that you would have rheumatoid arthritis. There is generally a female to male predominance in this autoimmune disease, as there is in many autoimmune diseases. And so that, of course, suggests that there's some role likely of sex hormones in the development of this disease. And generally speaking, this disease, the older you are, the higher risk you are for developing it. Actually, the highest rates of incidence are in the folks age 60 plus. But classically, it sort of starts emerging in young adulthood, and then there's a wide spectrum of range through the rest of your life in which it can arise. So how do we diagnose rheumatoid arthritis? Well, the short answer is you likely need a rheumatologist to help you diagnose this. Reaching a diagnosis often takes time. It can be a muddled process. Different hints, different slices come through at different times. Maybe the distribution isn't classic. Maybe the labs aren't positive, or they're not positive at the beginning. Maybe it starts with a feature beyond the joints. The point is, it can take time, and it often takes the expertise of rheumatologists to come up with this diagnosis. But fundamentally, the diagnosis is made through talking to the patient, interviewing the patient, and examining the patient. And so some of the characteristic symptoms and exam features we've already talked about. An important other thing to note is that the duration of symptoms and exam abnormalities needs to be 6 or more weeks. We'll talk about a little bit more in a minute. There are some other diseases that can kind of mimic rheumatoid arthritis that are ultimately transient. So lab testing, we alluded to this earlier, there are some key lab tests, the rheumatoid factor and the CCP antibody, also known as the ACPA, which are basically antibodies that you don't normally have present, that there's a citrulinated change that's been undertaken in your body, possibly in response to this chronic inflammation of mucosal sites. And it's not a normal feature of what we recognize with our immune system. And then finally, there's characteristic imaging findings. So, an ultrasound or an MRI, you might see evidence of swelling of the synovium, of that soft tissue that supports the joints and keeps them gliding with fluid in between the 2 surfaces of the cartilage. You also might see early erosions, meaning areas where the bone has eroded away, for permanent damage, basically, from the inflammation. Often plain x-rays don't show early changes, but with time, larger changes that are sort of evident and permanent, both the erosions, but also sort of what are deformations, so to speak, in the normal angulation and orientation of your joints can occur and be seen on x-rays. So, that data that you take in, this previous slide of data, you need to, as a clinician, come up with, well, is this rheumatoid arthritis, or what are some plausible alternate diagnoses? And if there are tests or features that can help you exclude these diagnoses, you can be more confident in your diagnosis of rheumatoid arthritis. And so in rheumatoid arthritis, you can see here with my cursor, I'm circling the viral arthritis. So viral arthritis meaning, inflammation in the joints that occurs either in the setting of or immediately following a viral infection. We can see that classically, we see that in a disease called parvovirus B19, which is actually the virus that causes fifth disease in children, the viral disease with the slapped cheeks you get in childhood. So that disease, if your kid has it and then an adult gets exposed to it, that adult may have a syndrome that looks like rheumatoid arthritis, but ultimately will go away. It just can take a few weeks where you're kind of uncomfortable. But certainly we wouldn't want to diagnose and start treating with immunosuppression a condition like that. Other viruses can do similar, can have similar manifestations, but parvovirus B19 is sort of the classic. There are certainly other autoimmune diseases in which arthritis, inflammation arthritis is a prominent feature. You can see this list I have here: lupus, psoriatic arthritis. You can see this patient has a large psoriatic plaque on his arm. Patients with psoriasis can get rheumatoid arthritis, but it is also quite common, relatively speaking, that they get psoriatic arthritis, which is treated differently in some cases. And so it's very important to make this distinction. Sjogren's syndrome, that's an autoimmune disease that causes inflammation in the salivary glands and the eyes that can reduce your tear production and your saliva production. Can also have joint effects. Inflammatory bowel disease, autoimmune disease of the bowel, Crohn's disease, can cause inflammation in the joints beyond the bowel, just like rheumatoid arthritis can cause inflammation beyond the joints. And then sarcoidosis, that's another autoimmune disease, classically affects the lungs, but can affect the whole body. Now, osteoarthritis, that is not an autoimmune disease. That's sort of your wear and tear, age-related arthritis that is far more common than rheumatoid arthritis. 10–12% of the country has this disease. But there are always gray areas in rheumatology, and depending on sort of an atypical distribution or kind of atypical symptoms, there can often be a gray area of these two diseases overlapping or even co-occurring. And then finally, on this list, there's arthritis that can be due to crystals in the joints. These typically cause attacks of arthritis, very vigorous arthritis for a few days or a week or two. You might know gout or pseudo-gout. This is a picture of a microscope slide with gout crystals, these sharp little crystals in there. But there's sort of a more atypical form of these diseases where they can persist in the joints. The sort of the swelling and pain and inflammation can persist in more chronic form, and that can sometimes look like rheumatoid arthritis. So your doctor's weighing all these different factors. He or she needs to make a diagnosis, but in the end, are they just plugging it into a list of criteria and saying yes or no? Well, there are criteria, so to speak. These are what are called classification criteria. This is a summary table. They're actually even more detailed than this. But classification criteria, that's sort of a term of art in rheumatology that basically means, well, it's meant to identify a subset of patients that with a disease that is more homogeneous, more similar than perhaps the wide range you can see in the real world. And the point is to identify a distinct focused population for clinical trials, for example, to know exactly kind of what you're dealing with. Generally speaking, if a rheumatologist says you fulfill the classification criteria for the disease, then I think most rheumatologists will diagnose you with that disease, but they are not diagnostic criteria. Just because you don't fulfill them or just because you do doesn't mean that you have the disease. Fundamentally, you have rheumatoid arthritis if the rheumatologist says you do. So we were alluding to this earlier, differentiating between rheumatoid arthritis and osteoarthritis. And like I was talking about earlier, there's sort of the classic distribution of rheumatoid arthritis. Earlier I was pointing out those MCP joints and those PIP joints, those big knuckles and middle knuckles, where you get the swelling and tenderness and warmth and inflammation. And the swelling is very kind of squishy and boggy. It has a characteristic feel on exam. That's why exam is so important in rheumatology. Osteoarthritis, age-related arthritis, you could say, the prominences are, first of all, they're in the farthest knuckle joint and the middle knuckle joint most classically. So you can see those changes in this diagram here. They often have these kind of bony lumps. It's very hard prominences and swelling. There's typically not a lot of bogginess or particularly a lot of warmth necessarily. So the pattern, the distribution, so to speak, what it feels like on exam is quite important. And the stiffness pattern, generally speaking, like I said earlier, in rheumatoid arthritis, the inflammation-mediated stiffness gets more, well, it improves with use over a few hours. Whereas in osteoarthritis, these joints that I'm circling here, they often become more painful with use. There's maybe stiffness for 5-10 minutes in the morning, just kind of when you get out of bed and make your cup of coffee. But generally speaking, joints with osteoarthritis get worse with use. And yeah, let's go on to the next slide here. So let's go back to our patient case. So this is our 35-year-old woman. She has progressive inflammatory arthritis of her hands and wrists, and she's found to have a positive RF and CCP antibody. So a rheumatologist diagnoses her with rheumatoid arthritis. And so that's a big diagnosis. That's a impactful few minutes there in the clinic. And so immediately the conversation evolves into discussing, goals and concerns and the treatment plan. And so the patient, her goals, she wants to reduce her symptoms and regain her function, get back to work. But she also, of course, is mindful about preventing any sort of permanent joint damage. Right now the disease is early. There's swelling. There hasn't been significant bony damage. Her fears, her concerns, a lot of these drugs that we use to treat this disease suppress the immune system, and that increases the risk of infection. So she's worried about infection. She's worried about side effects from the drugs. She's worried about permanent debility from losing the ability to work or do the things that she enjoys, activities. And of course, she's also worried, well, what does this portend for her children in terms of their risk of rheumatoid arthritis? And so I'll sort of pivot for a moment here, and those are some of the concerns the patient may have. Well, here are some of the questions we often get asked in those first few visits with our patients. A lot of patients, they wonder, why did I get this disease? Could it have been prevented? The short answer is we still don't fully understand how this disease arises. We have some risk factors we can identify, some of which we can modify, some of which we can't. The modifiable ones, smoking, first and foremost, your risk for rheumatoid arthritis is substantially lower if you don't smoke. So if you are smoking, stop. Don't expose your loved ones or be exposed to secondhand smoke. That's another important feature we've shown, a risk factor rather, that can be associated with the development of RA. Childhood exposure, ongoing secondhand exposure to smoke. Patient, this is sort of a different question, but kind of related. Some patients might come to me or another rheumatologist and say, well, someone checked a rheumatoid factor and a CCP antibody. I see them and I say, well, you don't have rheumatoid arthritis at this moment. But they want to know, will I go on to develop RA? And I can answer this question briefly. We have some studies in some other countries where we've looked at, for example, a random sampling of blood from a blood bank, and then later they go on, that's been stored and saved for research purposes, and they go on later and they look back and say, well, who among these patients go on to develop rheumatoid arthritis? The reality is, I didn't touch on this earlier, but the rheumatoid factor antibody is much less specific for rheumatoid arthritis than the CCP antibody. So actually, in this one study in Italy from about a decade ago, they found that the rheumatoid factor itself isn't actually, there isn't actually a statistically significant association with going on to develop rheumatoid arthritis. And again, remember, this is in patients, they're not even patients, they're people who donated blood. There was no reason to send the test. It's purely for a research purpose. Now, the question is different if your doctor, one of your doctors, sent a rheumatoid factor or CCP. There was probably something going on that triggered that. So that risk is harder to say. It's hard to put a number on this. It's kind of a similar situation with the CCP antibody. So the CCP antibody in that Italian study, those folks are more likely to develop rheumatoid arthritis in the future. And this is an antibody that in general is much more specific for rheumatoid arthritis. At the time of evaluation, when a rheumatologist is seeing the patient, the specificity for this test is pretty high. It's about 95%, meaning about 95% of the patients who have this test positive have rheumatoid arthritis at the time they're being assessed. Before they're being assessed, a little bit harder to say. The actual prevalence was pretty high. It was 4.7% in this Italian study. So 4.7% of all comers have this antibody positive. Well, that doesn't mean 95% of those patients are going to go on to develop rheumatoid arthritis, right? 0.5% to 0.75% of people develop rheumatoid arthritis over their whole life, right? So, however, that risk of developing rheumatoid arthritis, if you have a positive CCP antibody, is about, let me see my number here, about 20-fold higher among the CCP positive patients than among the non-CCP positive patients. So the short answer is if you have a positive CCP test and you see a rheumatologist and you're not diagnosed with rheumatoid arthritis at that time, it's a situation where you definitely should be monitored going forward periodically and know what to look out for, because your risk of developing rheumatoid arthritis is substantially higher. Hard to pin a precise number on it, though. So other questions commonly get asked in that first visit is rheumatoid arthritis a lifelong diagnosis? And essentially the answer is yes. This is not a diagnosis. This is not a disease that can be cured. It's one that is a chronic disease that is managed. You put it into remission, you live with it, on some medications, sometimes off medications. You don't necessarily have to be on treatment for life. Generally speaking, though, you're on some degree of treatment, some degree of management, and you get the disease into remission, and sometimes you can de-escalate your treatment and you do really well, but sometimes you de-escalate the treatment and the disease comes rearing back, or sometimes you're on a treatment and that treatment stops working. And so generally speaking, I counsel my patients that I anticipate you will be on some degree of treatment pretty much lifelong. Other questions that get asked right away is, well, is it going to hurt my joints if I exercise? That first visit, the joints are still inflamed. And the short answer is no, we encourage you to exercise. And it's been proven to reduce pain and certainly be beneficial in the long run. Keeps your muscles strong muscles offload kind of the bone-on-bone contact that can be painful. Exercise makes you feel good. It's important because rheumatoid arthritis, like I mentioned earlier, can cause weight loss. That inflammation can be harmful to your body kind of globally. And of course, we know that exercise is quite beneficial to you globally throughout your body. So it's important to fight back and to exercise. Patients want to know right away, will they be pain-free? And that is always my goal. My goal is to get patients into a low disease state or remission, disease activity state or remission. And often with that comes being pain-free. It can take some time, unfortunately, to find the right combination of drugs or achieve the sufficient drug treatment for the sufficient duration to actually get things better. And sometimes damage happens, damage accrues from this disease that then leads to some degree of joint pain that's going to stay, some sort of arthritis damage that's locked in, so to speak. So the answer to can I be pain-free is yes. It's always the goal. We work very hard toward that. But unfortunately, we do not achieve that in everyone at all times. So regarding how we achieve that, the treatment of rheumatoid arthritis. Well, like I said, the goal, we want to diagnose the disease early. We want to treat it aggressively early. We want to achieve control, tight control of the disease and prevent any permanent damage. So this is a picture of someone's hand. You can see these PIP joints, these middle joints, they're swollen. They're going to be a little tender and warm if you press on them. As you can see, it's a little bit more subtle, but there's swelling between the knuckles here in this hand. That's what it might look like. It's been going on for 6 months. You saw the rheumatologist a month ago. Now you're on treatment. Things are getting better. The goal is to prevent more of the chronic changes like this, where there's big bony changes and proliferative changes and swelling of the soft tissue, and the joints sort of can be angulated in a funny way due to damage. And so the tools we have what are called DMARDs, disease-modifying antirheumatic drugs, basically immune-suppressing medicines. And then we also have anti-inflammation drugs. So there's non-steroidal anti-inflammatory drugs, NSAIDs, things like naproxen or ibuprofen. And then we have steroidal anti-inflammatory drugs, glucocorticoids, steroids. The kind of archetypical one we all know is prednisone, which is used for a variety of conditions. Now, prednisone is also immunosuppressive too. So what are some of these more targeted drugs that we use to modify the immune system? Well, there's sort of the conventional ones that have been around for a while, a few decades, some of these a little bit longer than that. Hydroxychloroquine, methotrexate, leflunomide, sulfasalazine, these are all pills you take. And here's a picture of some methotrexate, which was originally used as sort of an anti-cancer therapy. We use it in much lower doses in rheumatology to exert an effect to modulate the immune system and kind of slow it down a little bit in a targeted way. There's all these new fancy drugs you might see on TV, some of which have actually been out for approaching 30 years now. But Humira, for example, is a very popular drug for the treatment of rheumatoid arthritis. It's an injection you do. Infliximab, Remicade, that's the same kind of drug, which is called a TNF inhibitor, but it's in an IV infusion, in an infusion center form. There are other drugs that act on other specific, what are called cytokines, kind of signals cells send each other to create and modify and rev up or slow down inflammation. And then there are these other classes of drugs, Orencia and rituximab, that act directly on our immune, our cells that are our immune system, our B cells and our T cells. And then there's these newer drugs, what are called targeted synthetic DMARDs. You also probably see these on TV, Xeljanz and Rinvoq, tofacitinib, these kinds of medications. These are actually pills. And they're a powerful class of drugs as well, although a lot of these drugs, they all have risk and benefit profiles in terms of side effects, in terms of how immune suppressing they are. Not all folks need quite so much immunosuppression because the disease is not so active relative to other folks. Sometimes we progress through these drugs in sort of an incremental escalation. If you don't respond sufficiently to or at all to one of these drugs, we try a different class of drugs. And this is actually only part of our armamentarium. This is sort of an overview. Rheumatoid arthritis is a common disease, and we have, frankly, more drugs that we use to treat this disease than anything else in rheumatology, thankfully. So if one drug isn't working or the third drug isn't working, we keep going because we have more options. So I alluded to this earlier, NSAIDs, non-steroidal anti-inflammatory drugs. You can see this picture here is a handful of ibuprofens. They're cheap, they're easy to use, they don't suppress your immune system, they have, in some cases, fewer side effects relative to these other drugs that we're talking about, the DMARDs, but they have disadvantages too. You can't just take high-dose ibuprofen around the clock forever. You're going to be at risk of stomach ulcers, and actually these medicines slightly increase your risk of heart attack and stroke in the long run, whereas some of our other medications or DMARDs do not do that. And that's very important. We'll talk more about that later. They also just aren't enough anti-inflammation effect often, quite often. So glucocorticoids, such as prednisone or injectable forms of it, like you see in this picture here, those are stronger and they act more quickly, or they act quickly. You can do a local injection into a joint. You can take it systemically by mouth or by IV. And they're quite powerful. But they are kind of blunt tools. They have a lot of side effects, unfortunately. And so high blood pressure, high blood sugar, weight gain, your skin can thin out and get kind of wrinkly and what we call tissue paper appearance. You can lose muscle mass. A lot of people, when they take this medicine, they can't sleep well at night. They get more anxious. It can cause cataracts and glaucoma, and it can cause osteoporosis, which of course places you at risk for fractures of your hip or your back. And glucocorticoids, prednisone, it is immunosuppressing. It increases your risk of infection. So let's go back to our patient. She's got rheumatoid arthritis. She wants to start treatment now because she wants to prevent any significant joint damage. But she's 35. She wants to have a second child. And a lot of these drugs, unfortunately, that we talked about can't necessarily be safely used in pregnancy or in someone trying to conceive. So often as in rheumatology, we're faced with the question of balancing treatment with reproductive concerns, because a lot of diseases do come on in young women. And so I'll just touch on this briefly here as sort of a single slide in our talk, but rheumatoid arthritis affects, pregnancy considerations are quite important in rheumatoid arthritis. And so rheumatoid arthritis itself, the disease sort of unchecked, we think it reduces fertility in patients. Good disease control prior to attempting to try to conceive, we think may improve fertility. Rheumatoid arthritis itself, we haven't shown there to be an increased risk of miscarriage, fetal loss, but there is an increased risk of preterm birth. Generally, actually, it's kind of interesting, rheumatoid arthritis activity generally improves some during pregnancy and then comes back with a vengeance afterwards. That's not all patients. Some patients are never in control during pregnancy and it gets worse. But generally, the disease improves slightly. There are a few of our DMARDs that we know are very safe in pregnancy, completely safe. And hydroxychloroquine is sort of chief among that. Sulfasalazine is another drug that we use, and that is shown to be safe in pregnancy. There's some DMARDs that are absolutely completely unsafe in pregnancy, and methotrexate and leflunomide are two that are very clear, not compatible with a safe gestation. Patients on these therapies, because we certainly wouldn't want them getting pregnant while on these therapies, we recommend that they be on what's called a long-acting reversible contraceptive. So things like a Mirena IUD or an IUD, or the implant you put in your arm called the Nexplanon. The failure rates on those are incredibly low compared to birth control pills, for example. So that's very important to consider if you are on a medicine like this and of reproductive age. So some additional questions patients ask sometimes. Will I become disabled? And we have some studies on this. A lot of our studies worldwide come out of Sweden or other countries that have sort of a centralized healthcare system and welfare state that where all this is linked up and easily tracked over many decades. And so this is an old study. It's from 2002 when it was published. And if you imagine them following patients for 10 years plus prior to that, we're talking about treatment of rheumatoid arthritis in the 90s. So in the 90s, in 2002, at the end of that, 94% of patients were still independent in their daily activities, cooking, moving around, transporting themselves, bathing, eating. 20% of them had basically no disability, and about a third with moderate or mild, a little bit more with moderate disability actually, and 10% pretty severe disability. And another number from the study is that about 20% of the patients really didn't have any symptoms at all at the conclusion of the study. Now this is 20 years ago when the study ended and reflects sort of a prior era for treatment. But these are relative numbers from a generation ago that are, I think, illustrative for us. The hope is that with earlier diagnosis in the modern era and more aggressive treatment right away and more aggressive escalation right away with these newer therapies, that we are going to experience substantially less joint damage and debility than what was seen in Sweden in the 90s. And we have evidence to a lesser degree of quality in different settings that suggest that is the case. Another question, does having rheumatoid arthritis increase my risk of other diseases? Yes, it is associated with increased risk of a variety of diseases. You can see a list here. Kind of chief among it is what we call atherosclerotic cardiovascular disease. So that's the kind of plaques in your arteries of your heart, of your brain that can cause heart attack, cause a stroke. That risk is higher. And that's an important thing to know when you have rheumatoid arthritis, because your risks need to be managed. We need to be on the lookout for these kinds of things. Whether it's checking your cholesterol and being more aggressive about following up with your doctor and staying on a cholesterol lowering medication, getting yourself checked out by your primary care doctor, your cardiologist more frequency, so to speak. Leukemia and lymphoma, so certain kinds of cancer we know are associated with rheumatoid arthritis, and we think these risks generally correlate with how controlled or uncontrolled your disease is. The more uncontrolled it is, the more high risk you are for these conditions. The treatments that we're on, that we put patients on for this, don't necessarily clearly cause an increased risk of cancer. Although that's a question we're always asking in any of our treatments. Infectious risk, that's generally a product of the immune suppression that we put patients on. They're at increased risk for infections. Osteoporosis I touched on, that's both the inflammation from the disease itself causes a change in how your bones, well, it basically causes a net loss in bone density, much more than we'd expect from age. And of course, prednisone or steroids is a huge risk factor for bone density loss. And that's why it's so important to get people on treatment, non-steroid treatment right away at diagnosis. Peptic ulcer disease, that's often a product of the NSAIDs or the steroids that we use. And depression, that's both a feature, clearly of the pain and debility that patients experience in this disease, and perhaps to some degree also it's less nailed down the causality here, but perhaps some factor of the inflammation of the disease is a factor in this depression as well. So some additional questions: will RA shorten my life? And the answer in years past was yes. So a 1994 study, so again, we're talking, we don't even really have any of those modern medications I mentioned, like Enbrel was the first one in 1994 was when it came out. Yes, you had to decrease lifespan by about 7 to 10 years. A study that came out last year in Denmark, 10-year mortality from in RA patients was the same as patients, all other patients who don't have RA, the general population. However, those RA patients, despite no increased risk of mortality, had, as we alluded to earlier, increased risk of heart disease. So you can see the different kinds of heart disease you can have: heart failure, meaning it doesn't pump well enough; heart attack, of course, 44% higher risk of needing a stent. These are the relative increased risks. So 51% higher risk of heart failure, 58% higher risk of a heart attack, 22% higher risk of a stroke. And that we think is a factor, is mediated by the inflammation of the disease, that chronic inflammation in rheumatoid arthritis. As much as we try to control it, it is damaging to our blood vessels and sort of generates this atherosclerosis. We're starting to wrap up a little bit. I wanted to call attention to this very helpful book, this guide that's put out by MGH. It's a patient-oriented book that, if my talk was you could think of as sort of the executive summary. It walks through many of the things we discussed in more detail with some more data and citations, but it's very patient-oriented, and I'd encourage anyone who has rheumatoid arthritis or a loved one with it to check out this book. You can get it online, but you can also, it's available in our bookstore here, or gift shop rather, here at MGH. And so some final thoughts, some sort of summary thoughts here. RA, it's common. Think of it as a lifelong disease. It's an autoimmune disease. It primarily affects the joints, but it's a systemic disease. It affects throughout the body, both fatigue, but also in specific tissues like the lungs, blood vessels, eyes. It can be controlled with a wide range of drugs, and these drugs are relatively targeted. Patients with RA can become pregnant. They can have a healthy pregnancy, and their disease can be controlled while pregnant. RA increases the risk of multiple diseases, chiefly heart disease and stroke, but with modern treatments, we hope that the added mortality risk, and we know that the added mortality risk of RA is diminishing. And so, final thought, we have here Renoir, certainly one of our most celebrated Impressionist painters. You can see that he died in 1919. So he died a long, long time before we had any recognition, really, or treatment of this disease. And this is a picture of him in 1910, so 9 years before he died. And at that point, he had RA for about 15 years. And it's subtle, but I mean, look how kind of thin and gaunt he is, and the swelling in his knuckles and the angulation of his fingers here. You can see how prominent his knees are relative to his thighs. This is a systemic disease. It's affecting his joints, but it's kind of globally debilitating for him at 15 years on. But on the opposite side of the screen here, I have a picture, a painting rather, that he painted the next year. He remained incredibly productive despite his disease activity, and really gave him a lot of purpose and focus beyond his illness to be able to have sort of a calling and a task like this that I think it was made those last 25 years of his life where he had rheumatoid arthritis a lot more manageable, even though we essentially had really no treatment back then. At best, some sort of early attempts at anti-inflammatory treatment. Certainly nothing that could prevent the progression of the disease. There's nothing noble or romantic about this suffering he sustained, but I think, I'm certainly in awe of his perseverance here. And, the fact that he was able to find joy and purpose in his work despite his disability and find that to be sustaining for him, I think is pretty inspiring, both for me, someone who treats rheumatoid arthritis, but also I think it's inspiring to many of our patients. So I guess I'd say kind of in conclusion to people with RA that RA is part of your life, but it doesn't have to define your life. And as much as possible, your rheumatologist will work with you to keep your disease an afterthought and keep you painting or whatever else is your true passion and drive in life. And so with that, I will open it up for any questions. We can leave some more Renoir on the screen here. I don't know, am I still visible on the in the video here? Do you want me to switch to pure video?
We can see
I
you.
know, yeah, you're great.
Okay.
Dr. Moore, that was fantastic.
Thank you, Dr.
You
Wilson.
led a really informative presentation, and there are a few questions in the chat. I would encourage you, again, for the attendees, if you weren't here right at the beginning, to post your questions in the chat, and I will present the questions to Dr. Moore. So the first one that came through is it common for RA to take more than a year to get control of in terms of pain?
That is, I would say, atypical. I would say there are certainly cases where we struggle and it takes time over more than a year. You have to iterate through multiple different drugs. That is the exception. But I'll be honest, some patients we definitely struggle, and I would say to bring it under control, taking over a year, that reflects multiple trials of drugs, and drugs often we have to give them a full 3 months at a time to really know, is this going to be enough? It takes time to rein in the immune system, but it certainly can.
Yeah, one of the things I heard you say that I would emphasize is also that it's so important to get treatment quickly. And so when patients present with painful joints to their primary care provider, it is really important for the rheumatoid arthritis to be recognized and the patient referred to a specialist. And sometimes that can take some time with getting that evaluation. And so there are a lot of things that can contribute to it, but I agreed with Dr. Moore. It really can take, we try to be as aggressive as we can to get the disease under control. Another question, is seronegative RA different? And does seronegative RA have less or different systemic effects like the heart and lung?
So seronegative RA, meaning RA where the RF and CCP antibodies are negative, but that in conclusion, we still believe the patient has RA. It, generally speaking, can be more difficult to control. There are certain treatments that we have found work in folks who have seropositive RA, but don't necessarily work very well in people who have seronegative RA, and kind of chief among that would be rituximab. In terms of systemic effects, I know that the risk of lung disease is higher in folks who are seropositive. I'm not sure about other tissues specifically. Dr. Bolster, do you know?
Yeah, all of the things that are outside of the joint, all of the extra articular things that are outside of the joint are much more common. They really predominantly occur in patients that have blood tests that are positive for rheumatoid arthritis. So that answers that second part. And then when you say that modern treatments decrease the incidence of the systemic complications of RA, do you mean DMARDs like methotrexate and Plaquenil, or does this have to include just the injectables and more recently developed medications? So do modern treatments affect the systemic complications?
So I'd say, methotrexate and Plaquenil, hydroxychloroquine, are outstanding drugs, and methotrexate is often the kind of cornerstone. It's one of the first drugs we reach for, both because some folks it's sufficient, and in some folks it's a good start, it's a good building block, and actually potentiates and prolongs our ability to use the more modern treatments. I think more so than the modern drugs being necessary. In some folks, methotrexate and hydroxychloroquine or drugs like that are enough to prevent these other complications. But in many folks, they're not. And we build on or pivot from these drugs. I think it's just as important to recognize the disease early and get evaluated early. It doesn't mean that we have to leap straight to one of these injectable drugs necessarily. In some folks, methotrexate is enough. And again, often methotrexate plus another drug is perfect and a long-term solution. And we reach that conclusion in months. It's not a, at least in the modern era, it's not something that we can predict necessarily who's going to respond well to one therapy versus another. Of course, that's sort of the holy grail in rheumatology right now, is personalizing these diseases, or the treatment rather of these diseases. I think we're hopeful that with time there'll be genetic tests or a test of your microbiome or factors that we can test at the time of diagnosis to predict, to tell us what to go to, so we don't waste time, spend time without disease control.
Would you say that it's fair to say that if a medicine controls the arthritis, that the kind of constitutional symptoms that you talked about, the fatigue and reduced appetite and that kind of thing, that those also improve when the arthritis improves?
Yeah, I'd say, thank you, Dr. Wells. I'd say that the joint disease is a very good proxy for the systemic disease. Often these, for example, vascularized rheumatoid arthritis, it's pretty rare. We typically see it when the joint disease is quite severe. So generally speaking, as a proxy for your total disease control, if your joints are doing well, I think you can feel confident that as best as we can understand the systemic aspects, we are not fearful, particularly that they would be progressing.
There are lots of nice comments to you, Dr. Moore, on such a wonderful presentation, how comprehensive it is. I'm going to take the liberty of being on the panel and answering one of the questions. Is gold ever used anymore? No. And then it's not even available as far as I know. There's a question here that relates to patients with rheumatoid arthritis who are on methotrexate regarding the timing of the COVID vaccine. I think this is usually such a personal, individualized decision, but there are some guidelines. So maybe, Dr. Moore, if you want to address the guidelines, but yeah. Again, I think this is something that each patient should discuss with their doctor.
Yeah, so the American College of Rheumatology, our professional society, has come up with some guidelines about this specific set of questions. And, the short answer is, or the background is rather, that methotrexate suppresses your immune system and you need a robust immune response to the vaccine in order to create that protective immunity. So it's this balance. You might ostensibly want to reduce your immune suppression around the time you get the vaccine, so that you get a better response to the vaccine. Unfortunately, that comes at a risk of your joint disease or your autoimmune disease flaring up. And so every drug is different, every patient's situation is different, but generally speaking, our professional societies have come out with guidelines, which are basically just expert opinion, sort of our best guess based on some research, but also just our best opinion. would say that if your disease is under good control and your rheumatologist and you have a conversation about the risks and benefits of holding the medicine, then ideally you would hold the methotrexate for 1 to 2 doses after each vaccination in order to have a better response to the vaccine. It gets more complicated with other medications, particularly rituximab, which is an IV infusion that's given every 4 to 6 months and is unique in the way it reduces your ability to make response to vaccines. The short answer is talk to your rheumatologist.
Yeah. There's a question about whether the serum levels of rheumatoid factor and anti-CCP correlate with disease severity. Should these be monitored? Do they go down with treatment? And then there's a second question. Well, let's do that one and then I'll ask you the second question.
Generally speaking, we don't tend to track the levels of the RF and CCP antibody. I'll say that if an CCP level is equivocal, it's like right at the level of normal versus abnormal. It's 5% above the normal limit versus it is 100 times the upper limit of normal. Yes, I think there's a signal there in terms of predicting whether or not you have rheumatoid arthritis, and perhaps a signal towards how severe things are going to be at the time of diagnosis. I think the degree to which those antibody levels might vary with treatment isn't a reliable predictor of disease response or any sort of ongoing predictive value from my understanding. So we don't routinely recheck going forward. And then the second part is screening or primary prevention guidelines for diseases associated with RA, such as heart disease. I think there are paradigms for screening for osteoporosis, for screening for heart disease in the general population. Some of these screening tools take into account the use of prednisone or the use of autoimmune disease or the presence of an autoimmune disease. Not all of them do. The ones that don't take into account this factor of this chronic inflammation of RA, I think you have to sort of individualize your risk assessment. I honestly can't remember whether or not the standard ACC, American College of Cardiology 10-year cardiovascular risk calculator includes rheumatoid arthritis or not. I don't believe it does. So there are numbers for the general population, there are models, there are tools, but I think you have to work with your doctor and say, well, my risk is higher than this, isn't it? And then individualize your decision-making based on that.
If I could add to that, I would just say that there are studies that show that having rheumatoid arthritis is equivalent to having diabetes in terms of risk for heart disease. And we know diabetes is so highly associated with risk for heart disease. So it is really important that all what we call modifiable risk factors are addressed very readily with your primary care doctor if you have rheumatoid arthritis. And that would include things like your blood pressure or your cholesterol. And certainly if you smoke, these are all things that can be treated and modified. You can't get rid of rheumatoid arthritis, but you can certainly have it treated and improved. There are more questions, believe it or not, in the chat. There are also lots of congratulations to such a tremendous talk. I do have
I think right now.
Yeah, I think we need to wrap up at 1. So thank you, Dr. Moore, and thank you, Amy, for this opportunity.
Of course, thank you so much.
Thanks to the attendees.
Thanks, everyone.
Thank you. And as I had mentioned earlier, if you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.
Bye-bye.